Today we will discuss about the neurology. The embryology portion of the neurology. So that is again the most lengthy portion in the USMLE Step 1. So the embryology. The embryology begins with neurology. Embryology begin with the ectoderm. Ectoderms converted into neuroectoderm. This neuroectoderm form neural plate, right? So, which thing induced the ectoderm to convert into neuroectoderm or neural plate? That is a notocode. That is again a high yield point. So, notocode induced this ectoderm to convert into neuroectoderm and then neural plate, right? Okay. Then this neural plate fold, this neural plate fold and fuse together to form neural tube. These folds fuse together and form neural tube. Okay, so the some portion of this neural plate does not become the part of this neural tube and that remain as neural crest cells. The neural crest cells are not the part of the neural tube, right? So again, so the origin is of the neural tube is neuroectoderm, which is originate from ectoderm, and the underlying thing that conversion of ectoderm into the neuroectoderm is a nucleus pulposus, right? Oh, sorry, it's a notocode. Nucleus pulposus is the remnant of the notocode, right? The remnant of the notocode is a nucleus pulposus. The notocode is a structure that induce conversion of this ectoderm into the neuroectoderm, right? So let's suppose I magnify this neural tube. So this is a neural tube, let's suppose. So the lateral portion of this tube is divided into the two things. So the dorsal portion, let's suppose this is a dorsal portion. This one is a dorsal portion, and then this green color show the interior portion, right? The ventral portion. This is motor, right? Like similar to like ventral horn of the spinal cord, which is a motor, and dorsal horn, which is a sensory. So similar arrangement in the some sort of neural tube, right? So this dorsal plate is also known as ulnar plate, right? So this ulnar plate or dorsal plate is sensory and that is induced by BMP, right? Or that this plate that is a motor in nature is induced by SH, is same orientation as spinal cord. So again I'm revision. So ectoderm convert into neuroectoderm, right? This neuroectoderm form neural plate. This neural plate forms neural folds. This neural folds fuse to form neural tube, and the part of uh, the neural plate that not become the part of the neural tube that remain as a neural crest cell. The neural crest cell is again high yield. So I am discuss these neural crest cell in detail after a few minutes, right? So I hope it makes some sense. Okay. So again, if you magnify, if you magnify the neural tube, this is the neural tube. The neural tube has a three primary vesicles like prosencephalon, mesencephalon, and rhombencephalon. So three primary vesicles are present in the neural tube. Then these three primary vesicles divided into the further five secondary vesicles. So this is prosencephalon divided into the telencephalon. and diencephalon. If this prosencephalon not divided into the telencephalon and diencephalon, what pathology can take place? Again, the high yield step, that if this division not take place, there is association with holoprosencephaly. If this prosencephalon not divided into the telencephalon and diencephalon, then the pathology known as prosencephaly. Sorry, holoprosencephaly. Holoprosencephaly. Okay, don't worry about this. We will discuss this pathology in detail. So the key thing, this prosencephalon divided into the two secondary vesicles, that is a telencephalon and diencephalon. One more thing, the this neuroepithelium, this this give rise the wall, mainly this wall give rise the brain structure, different brain and brain stem structure. While this cavity, while this cavity give rise to the ventricle portion, ventricle and cerebral aqueduct. So wall give rise to brain and brain stems, while the cavity, this cavity give rise to ventricle. Okay. So these five secondary vesicles, the wall of the telencephalon give rise to the cerebral hemisphere and the basal ganglia. So wall of the telencephalon give rise to cerebral hemisphere and the basal ganglia. And the cavity of the cerebral hemisphere and the basal ganglia is a lateral ventricle, right? So the lateral ventricle is a cavity of the cerebral hemisphere and the basal ganglia. While the diencephalon, so this is the wall of the diencephalon. So the wall of the diencephalon give rise to the thalamus and hypothalamus. And again, important stuff, that is a retina, right? So what is a cavity? What will be the cavity of the diencephalon? What is the cavity of the diencephalon? It is a third ventricle. It is a third ventricle. What will be the cavity of the telencephalon? It's a lateral ventricle. So these things, wall and cavity, is again an important step, right? You have to cram the which wall of the telencephalon give rise to cerebral hemisphere, basal ganglia. Okay. So the mesencephalon, only one secondary vesicle, so it give rise to the midbrain. What will be the cavity of the midbrain? Is cerebral aqueduct, right? So one high yield pathology related to the cerebral aqueduct stenosis. We will discuss cerebral aqueduct stenosis in detail, right? So the rhombencephalon divided into the two secondary vesicles, right? So these are metencephalon and myelencephalon. So this metencephalon give rise to the pons, this wall of this metencephalon give rise to the pons and cerebellum, right? While the walls of the myelencephalon give rise to the medulla. So metencephalon cavity give rise to the upper part of the fourth ventricle. And while the myelencephalon cavity give rise to the lower part of the ventricle, right? So the again I am emphasizing three primary vesicles and five secondary vesicles, right? So neural tube has three primary vesicles and five secondary vesicles, and the wall of these vesicles give rise to the brain and brain stem structure, while the cavity of these neural tube give rise to the ventricles and aqueduct. Okay, so one more thing. So what is a neural crest cell? Neural crest cells that are not the part of this neural tube, that remain outside the neural tube. So can anybody tell me what are the adult structure that are derived from the neural crest? This is again a high yield stuff. So neural crest cells give rise CNS neurons, peripheral nervous system neurons, peripheral nervous system, glial cells, right? And adrenal medulla. Which cells? Adrenal medulla, chromaffin cells. So the pheochromocytoma is a tumor of the adrenal medulla. Adrenal medulla, and this tumor is derived from neural crest cells, particularly the chromaffin cell. This is the high yield stuff. And peripheral nervous system neurons. It may include the dorsal root ganglia and autonomic, whether it is a sympathetic and parasympathetic ganglia. What about the glial cells? The glial cells are basically the coating cells. So the high yield stuff related to these glial cells are Schwann cells. So what is the function of the Schwann cell? Myelination. Myelination of peripheral nerve, right? Myelination of the peripheral nerve. In which pathology these cells are damaged? It is damage in which pathology? Can anybody tell? GBS. What is the marker of the Schwann cells? Again a high yield. Again a high yield. Schwannoma, the tumor. So the marker is S100. They are S100 positive, right? So each Schwann cell myelinate only single axon. So they myelinate only single axon. Only single axon. Okay. What are the which cells are responsible for the myelination of the central nervous system neurons? Can anybody tell? Rock, can you identify which cells are responsible for the myelination of the central nervous system neurons? The high yield concept. Okay. So these are oligodendrocytes. So let's make a table that highlights the difference between the Schwann cells and oligodendrocytes. Okay, so let's make a difference. Schwann cells, oligodendrocytes, high yield. These differences are high yield. Oligodendrocytes. So oligodendrocytes myelinate central nervous system neurons, while the Schwann cells myelinate peripheral nervous system neurons. Schwann cells myelinate one axon only. Oligodendrocytes myelinate multiple axons. Multiple axons, right? While these Schwann cells are damaged in GBS, right? Oligodendrocytes damage in multiple sclerosis. Multiple sclerosis, leukodystrophies, leukodystrophies, and progressive multifocal leukoencephalopathy, right? So the Schwann cells myelinate the peripheral nervous system, but the exception of these are cranial nerve 1 and 2. So these nerves are not myelinated by Schwann cells. These nerves are myelinated by oligodendrocytes, right? So that's why in GBS, these things are not affected. Cranial nerve 1 and 2. So these nerves are affected in multiple sclerosis because multiple sclerosis oligodendrocytes are damaged, right? Okay, one more thing. So the glial cells are divided into two types. Glial cells. CNS glial cells and peripheral nervous system glial cells. So the CNS glial cells are included astrocytes, oligodendrocytes. We already discussed about the oligodendrocyte function and microglia. Okay. One more is ependymal cells. Ependymal cells. Okay. While the peripheral nervous system glial cells are satellite cells, and Schwann cells. Okay. What are the function of the astrocyte? So the one high yield function of the astrocyte is component of blood-brain barrier. Okay. So another function is support and repair. Support and repair. Okay. It also remove the excess neurotransmitter. Remove excess neurotransmitter. So what is the marker of astrocyte? GFAP. While the marker of the Schwann cells is S100. Again, the high yield. Why? Because in astrocytoma tumor, GFAP is positive, while in the Schwannoma tumor, S100 is positive. So these things you keep in mind. High yield stuff, right? So we discussed astrocytes, oligodendrocytes. What about the microglia? So microglia cells are derived from which layer of germ cell? Which layer of the germ layer? Which layer of the germ layer? Mesoderm. So these are mesodermal in origin. So microglias are mesodermal in origin, high yield, and these are the CNS phagocytes. So these are the CNS phagocytes. Microglias are CNS phagocytes. So in HIV infection, in HIV associated dementia, so sometimes these microglia fuse to form multinucleated giant cells. So this is again a high yield point. So in HIV associated dementia, these microglia cells fuse to form giant cells, multinucleated giant cells. Okay. So what are the ependymal cells? Ependymal cells. So ependymal cells are basically the lining the ventricle and the central canal of the spinal cord, right? So they are important in CSF production and absorption, right? So they are part of the choroid plexus. So they are involved in CSF production. So these ependymal cells lining the ventricle. So satellite cells are similar function as the astrocytes, but they are not a part of blood-brain barrier, right? We already discussed about the Schwann cells. Schwann cells are the myelinating cells that myelinate peripheral nervous system neuron, right? And damaged in GBS. Can anybody tell me that GBS is associated with microorganism? High yield. GBS is associated with which microorganism? Rock, rock. So GBS is associated which microorganism? Can anybody tell? Again, a high yield association. GBS.
Campylobacter jejuni.
Excellent. Campylobacter jejuni. Campylobacter jejuni, right? So the Campylobacter jejuni is associated with GBS. Absolutely right. Right? So GBS patient, so why it is important? So they give you the clinical presentation of the GBS. So how the GBS patient present? How the GBS patient present? So GBS present with symmetric ascending muscle weakness paralysis, right? And absent deep tendon reflexes. They give you this kind of the clinical vignette and the presentation uh, association with Campylobacter jejuni, and you have to identify what is the pathophysiology, which cells are damaged in this disease, right? Okay. Okay, I hope my screen is again visible. Okay, so this is again the central and peripheral nervous system. We already discussed about the neuroepithelia in the neural tube give rise to CNS neuron, CNS glial cells. We did discuss these things in detail. Function of these glial cells already we discussed. These are derived from the neuroepithelia in the neural tube and the neural crest. So this is the peripheral nervous system neurons, which is the dorsal root ganglia or the autonomic ganglia, and the glial cells, Schwann cells, satellite cells, and adrenal medulla. Adrenal medulla, high yield. because the tumor of the adrenal medulla is a pheochromocytoma. It's derived from the neural crest. So mesoderms give rise to microglia, which are the macrophages. We already discussed about the function of the macrophages, microglia, and they form giant cells in HIV associated dementia. Again, these things are high yield, and the difference between the Schwann and oligodendrocytes and their high yield pathologies, GBS, multiple sclerosis, super high yield. Their differences are high yield, right? So these are the super high yield stuff. Okay. So neural tube defect, again, super high yield stuff. So the neural tube defect. So the neural tube defect, it may be due to the failure of the, let's suppose this is a neural tube. So this is the rostral portion. This one is a rostral portion. And this one is caudal portion. If the caudal portion of the neural tube does not fuse, it will lead to the spina bifida. Spina bifida. While if it is due to the rostral, then it will lead to anencephaly. Anencephaly, no brain, no brain. Okay, so neural tube defect are associated with neural tube defect are associated with which thing? Neural tube defect are associated with folate, folate deficiency, folate deficiency and maternal diabetes. So the maternal diabetes and folate deficiency increase the risk of the neural tube defect, right? Okay. So in neural tube defect, in neural tube defect, the maternal serum alpha fetoprotein is raised, right? Again, a high yield stuff. This alpha fetoprotein is normal in spina bifida occulta. It is normal in spina bifida occulta, right? So what will be the confirmatory test for the neural tube defect? Confirmatory test in the neural tube defect is it is a increased acetylcholine esterase, increased acetylcholine esterase in amniotic fluid is helpful for the confirmation of the neural tube defect, right? So increased alpha fetoprotein is normal in spina bifida occulta, right? So spina bifida occulta is closed neural tube defect, while these are open neural tube defect. Okay, just focus on this picture because these pictures explain a lot of stuff, right? So this is, look at this picture, this one. This is the normal. This one is a normal, right? So this is a normal picture. So this is a leptomeninges. Leptomeninges include arachnoid and pyometer. And inflammation of the leptomeninges is known as meningitis. So, and this is dura. So the leptomeninges, dura, and the spinal cord, and this is intestine, right? What happened in the spina bifida occulta? So in spina bifida, so there is a defect. There is a defect at the lower vertebral level, right? So this dura leptomeninges are intact, but there is a bony defect. Bony defect in vertebral arch. What this bony defect in vertebral arch, high yield stuff. So there is a bony defect in a vertebral arch in spina bifida occulta, right? Okay, and there is a maybe the tuft of hair and skin dimple. So they give you the this kind of the description in your questions, and they want to know about the association of this pathology. This pathology is association with maternal diabetes and maternal folate deficiency, right? Okay, so this is spina bifida occulta, the neural tube closed defect. While these two are, while these three are open neural tube defects. So meningoceles, look at that the picture. In the meningoceles mean meninges are herniated. So these meninges are herniated through these bony defects, and there may be skin defect or thinning. While in myelomeningocele, so the neural tissue, spinal cord, and the meninges both are herniated through the bony defect, right? So these are meninges and these are spinal cord, and this is the defect. So meninges plus the neural tissue, which is the spinal cord and its other structures. So they herniate through the bony defect, right? So again, they want to know about this kind of the thing and their high yield association, which is the maternal diabetes and maternal folate deficiency, right? Last one is a myeloschisis. Myeloschisis is again the open neural tube defect in which exposed and unfused neural tissue without skin and meningeal covering. So anencephaly, it's open neural tube defect. So as we already know that. Hello. Okay. So what happened in the anencephaly? What happened in the anencephaly? So this is the open neural tube defect in which failure of the rostral neuropores, right? So there is a no forebrain and it is present with the polyhydramnios, right? Okay. Let's move towards the brain malformation. There are the two brain malformation that are high yield, that is holoprosencephaly, right? So holoprosencephaly is basically we discussed the prosencephaly is not divided into diencephalon and tenencephalon, right? So there is a one primary neural tube vesicle. It's not divided into the secondary vesicle, right? So what happened? So there is on picture you find that there is a monoventricle. So sometimes they give you this kind of the picture similar to this picture, monoventricle, and they want to know about their high yield association. So what are their high yield association? Is Patou syndrome and fetal alcohol syndrome, right? So the okay, so their high yield association at the Patou syndrome and the fetal alcohol syndrome. So this kind of the picture you find in your questions in Q banks and assessment, this kind of the picture, and they want to know about what are their high yield association. So these single cerebral hemi. Okay. Okay. So holoprosencephaly, again, the revision of holoprosencephaly, you find this kind of the picture, monoventricle, right? So association with Fatu syndrome, trisomy 30, fetal alcohol syndrome, IEL1, and SHH mutation. Right. So the forebrain prosencephaly not divided into the secondary vesicles. So that's why it's on the imaging you find the monoventricle. So it's present with a midline defect. So the cleft lip and palate, sometimes they give you this kind of the clinical vignette. Hypotelorism. So the hypotelorism is basically the abnormal distance between the two eyes, right? So cyclopia and pros, proboscis. So this is a difficult to pronounce. So basically, it is another condition where what happens in prostobiosis that the nose is not at a normal place. In cyclopia, the two eyes are fused and present at the abnormal location, like at the forehead. So the increased risk of the pituitary dysfunction, the diabetes and insipidus, because the forebrain is prosencephalon is not divided into the two secondary vesicles. So next brain malformation is a lesioncephaly. So again, this picture is an important one. You look at on the picture, there is a no sulci and gyri. From when you compare this picture from this one, there is a no sulci and gyri. So this is a typical smooth brain. So the smooth brain, so it will present with this presentation with typically with microcephaly, microcephalic child. So dysphagia, seizure, and some sort of the facial anomaly, right? So these images and try to the holoprosencephaly is the most high yield one in the brain malformation. So these are incompatible with the postnatal life. So child is always severely disabled. Okay, some other high yield pathologies. Okay, so again, this is again the high yield one. So the posterior fossa malformation. So the posterior fossa malformation, these are C1, carry one. One means the one thing is displaced. It is a cerebellar tonsil. Cerebellum. In two, cerebellum plus medulla, right? So in one, the cerebellar tonsil is displaced. So look at this as cerebellar tonsil. So it is displaced through the foramen magnum. This is which one is the carry one malformation. So this is again the picture of the carry one malformation. So this is again the cerebellum or cerebellar tonsil. This one is a displaced through the foramen magnum. And this is the syrinx. Syrinx is basically the cavities within the spinal cord. Cavities. These are the cavities within spinal cord. So it is associated with syringomyelia. So the Chiari one malformation is associated with syringomyelia, while the Chiari 2 malformation is associated with non-communicating hydrocephalus. So the non-communicating Chiari 1 is associated with syringomyelia. This is again a high yield one. So is that typically the patient are asymptomatic in the Chiari one malformation, while in two it is a symptomatic. So the differences between two, one is associated with syringomyelia, two is associated with one and two. So one is associated with syringomyelia. So one is typically usually asymptomatic, while two is symptomatic, right? So in one, only cerebellar. So cerebellar tonsil is displaced through foramen magnum, while in the Chiari 2, cerebellar plus medulla both are displaced through the foramen magnum. Both are displaced through the foramen magnum, right? And it is associated with non-communicating hydrocephalus, not associated with syringomyelia, and it is present with an early life with dysphagia, sided apnea, and the limb weakness, right? So the two is associated with non-communicating hydrocephalus. One is associated with syringomyelia. Two is also associated with myelomeningeocele. What is a myelomeningeocele? It is a herniation of meninges plus neural tissue, right? Okay, so Dandy-Walker malformation. It is a simple is agenesis of the cerebellum vermis. It is a agenesis of the cerebellum vermis, and there is a cystic enlargement. The cystic enlargement of the fourth ventricle. So this picture, you find these kind of picture in your Q banks as assessment. So these kind of the picture are in neuroanatomy or neurology. The sections, the pictures are high yield. To focus on these kinds of pictures and their presentation. Okay, so this is cystic enlargement of the fourth ventricle. Simply, it is a agenesis of the cerebellar vermis, and this is again associated with both of these two. Chiari 2 and Dandy-Walker malformation is associated with non-communicating hydrocephalus. So we will discuss the hydrocephalus in detail. There are two types of the hydrocephalus. We will discuss the obstructive and non-obstructive. So, so this is non-communicating mean obstructive, right? There is obstruction due to this downward displacement of the cerebellum and the medulla, right? Okay, this is the last topic of the today, syringomyelia. The syringomyelia, what is a syringomyelia? It's a basically fluid-filled cavity. Look at this picture. This is fluid-filled cavity within the spinal cord, right? So, lateral spinothalamic tract. Lateral spinothalamic tract carries which sensation? Lateral spinothalamic tract. So it carries the pain and temperature. The pain and temperature. So again, look at that picture. So this is dorsal root ganglia. So these are the sensation comes, and look at that. These things crossing over to the opposite side, and they form interior white commissure, right? So this is interior white commissure, right? And this is the pharynx, the cavity, fluid-filled cavity, and this compress this interior white commissure, which is the basically the fiber of the lateral spinothalamic tract. So from the both sides, so the right and left. So this pharynx initially compress the lateral spinothalamic fiber, which are the interior white commissure, right? So these ones. So when these fibers are compressed, the patient has loss of the sensation of the pain and temperature, on both sides, right? Okay, as this syrinx expand, it will compress the interior structure, interior horn. So the interior horn is motor. So if this syrinx is expand in this way, so it will compress the interior horn, and interior horn is motor. So patient present with lower motor neuron deficit. The patient present with motor neuron deficit. Okay. Okay. So the presentation of the patient is basically the cap-like loss of pain and temperature sensation in bilateral upper extremities, right? Bilateral upper extremity because the most lesion occur between T2, T9. That's why it's typically the loss of sensation bilaterally in the upper extremity. If this pharynx expands interiorly, it will compress the interior horn and the patient present with the lower motor neuron deficit, right? So this is associated with carry one malformation. We already discussed the carry one malformation is associated with syringomyelia. Like this is again carry one malformation. The cerebral tonsil is herniated through the foramen magnum, and this is pharynx, fluid-filled cavity, right? So you know that which tract is damaged in the syringomyelia early. In the early, the lateral spinothalamic tract is damaged, while when this syringos, this milia is expanding interiorly, this pharynx, it will damage the interior horn as well. And in this way, the patient may present with the lower motor neuron deficit as well as loss of pain and temperature sensation in the bilateral upper extremities, right? And the most typical location is T2 and T9, and it is associated with carry one malformation and less commonly associated with infection, tumor, and trauma.